Through innovation, academic excellence, and family-centered clinical care, Children's Mercy Kansas City is transforming outcomes for children around the world. Welcome to the audio interview series, Transformational Pediatrics, with host Dr. Michael Smith.
Our topic today is double balloon enteroscopy. My guest is Dr. Thomas Attard. Dr. Attard is a pediatric gastroenterologist and medical director for endoscopy services at Children's Mercy Kansas City. Dr. Attard, welcome to the show.
Hi, thanks for having me here, Dr. Mike.
Sure. Let's first talk about some of the basics of what we're going to call DBE, double balloon enteroscopy. What exactly is it and how does it work?
So as you're definitely familiar, we have been doing endoscopy, both upper endoscopy, meaning what we call EGDs or esophagogastriduodenoscopy, as well as lower endoscopy, which we call colonoscopies now for many years in adults and certainly in kids. But there's always been this frustration about not being able to get in the bowel that's between how far in we get from above and how far in we get from below. So, most people forget the small bowel actually is about 17 feet in length. And if you think about it, we're only looking at the first maybe half foot from the top part and maybe a half foot from the lower part, leaving you 16 feet of bowel, which can have quite a bit of pathology that we never actually get to or in any other way look at. Now, through the years, as most people are aware, we've been doing barium studies and then moved on to having CT scans and MR studies. And then more recently, we've been doing what are called capsule enteroscopies. So you swallow a pill cam. You're probably familiar with that technique. And then the physician, the gastroenterologist, actually sees a video feed of the whole small bowel. And that's all great, but it doesn't allow you to get biopsies from whatever you see. So the double balloon enteroscopy is really the kind of the state of the art of endoscopic techniques to get to be able to go into the small bowel to sample tissue that you're interested in that may look abnormal on other studies, and to actually intervene and cure some of the conditions we deal with. For example, with Peutz-Jeghers syndrome, we get small bowel polyps that can actually transform into neoplastic malignant polyps later on that we can actually go ahead and take out before they cause too much trouble. So double balloon enteroscopy is quite sophisticated. It's a fairly long procedure compared to most other endoscopies, but it kind of allows us to get into areas which we haven't gone there before, at least.
And so obviously you have the advantage or the benefit of being able to visualize more bowel. Are there any other advantages to doing DBE?
As I said, you visualize it, but you can also intervene upon it. So you'll know exactly where you're going in terms of the scope. You know how far in the pathology is. If there's something, for example, that you see, but you can't do anything about endoscopically, then you're actually going to help the surgeon considerably by actually tattooing the area. So we can actually inject some dye into the wall of the bowel, and that allows the surgeon at a later date to actually find whatever lesion you are interested on the inside, to isolate it and probably resect it sooner. So it is quite. It does allow you a lot more, certainly a ton more access than conventional endoscopy used to, and better diagnostic capabilities than capsule endoscopy does at this point in time, at least.
So do you see, Dr. Attard, is DBE going to be pretty much the gold standard approach for endoscopy, or are there ideal patients for this?
There are both. Yes, it definitely is the gold standard. There's no comparison of any degree of radiologic or even real-time images through capsule to being able to biopsy and identify a lesion. So there's no question that it represents the ultimate test of what's going on. The problem is, however, that being so invasive, I don't see it as replacing any of the other techniques. I see it as the obvious and the natural plug-in to what we already are doing. So instead of kind of quitting on finding out what's going on after we have images or X-rays or MRI scans. We can now go a step further, short of surgery. Still fairly invasive, of course. It is a procedure under general anesthesia, and it has significant risks more than a regular endoscopy. But it allows us to kind of complete the gamut of diagnostic workup that we are offering these patients. And is there the ideal patient? Yeah, exactly. As was implied by the answer, is the patient who has been worked up for what we call obscure GI bleeding, negative endoscopies, meaning endoscopies that failed to find a cause for bleeding in the gastrointestinal tract, perhaps negative also either MRI or capsule endoscopy, or maybe difficult to interpret results. So when you're at your wit's end, basically, with all the other studies, that's when DBE kind of wraps it up and tells you what's going on in the small intestine. So the ideal patient is the one who has failed far less invasive and the traditional techniques.
So Children's Mercy is still one of the few institutions that does DBE on a regular basis, correct? And what's been your experience as a clinician overall with it?
So I trained in Sheffield in the UK with Dr. Mike Thompson to do some of these. In the United States, there are. I was asked how many exactly at one point, and I don't know exactly how many centers do this, but I'm imagining not more than 5 or 6 centers. I could be off maybe by 1 or 2, but I don't think so. So it's ultimately a test which I don't think should be perhaps attempted at every center, because not a lot of centers have a huge volume of patients, and this is something that is clearly very operator dependent. It's not a very straightforward procedure. It does require a fair amount of skill, and that skill has to be maintained. So if a center commits itself to doing them, it's actually doing quite a few. So I do think it is something that fits very well with what Children's wants to do in endoscopy. We want to be able to offer all the services, and we certainly think to have the volume that actually made us want to develop DBE, so that we can deliver better care. And we also get to all the unusual diagnostic challenges rather than just the straightforward issues, and that does then require us to go kind of the extra mile with finding new techniques that perhaps aren't available all over the place.
So DBE will be a procedure that will probably stay in the hands of the highly trained specialists at the very specialized hospitals. Is that right?
Yeah, I can't imagine being otherwise, yes.
Well, Dr. Attard, I want to thank you so much for coming on the show, and thank you for all the work that you're doing. You are listening to Transformational Pediatrics with Children's Mercy Kansas City. For more information, you can go to childrensmercy.org. That's childrensmercy.org. I'm Dr. Michael Smith. Thanks for listening.